for the last talk, we elected to discuss an issue that is not necessarily something that you see on a daily basis in your practice, but it is a very controversial issue both for the parents, for the pediatricians, and for the specialists who are asked to evaluate these patients. And as soon as I find... Okay. And here we are. So the issue is Pectus excavatum, and as you all probably know, it is a genetic abnormality of the rib cage, and what it consists of is an inward displacement of the sternum that creates this hollow shape on the chest wall. Like a lot of other conditions, there is a spectrum. Not every single patient has exactly the same problem. So there is the classic one, in which case you have a fairly central and relatively symmetric displacement of the sternum inward. Then you have the unbalanced one, that you have not only the inward displacement, but you have pretty significant asymmetry in the rib cage. And then you have the flat one that, I'm sorry, that essentially it is, think of it, you know, like if you grab the rib cage of somebody with giant hands and you squeezed it, you know, and you flattened it. Clearly, as we're going to show a little later, any kind of abnormality is going to have certain effects, and this is what you and us are being called to evaluate. In terms of the etiology of the Pectus excavatum, still it's not very clear. The belief is, and there is evidence for that, that essentially it has to do with the structural abnormalities of the mesenchyma. Essentially think of it, you know, like the scaffolding. If you think of the rib cage as a structure, it is the scaffolding of this structure when it's being built that is defective, and as a result you have all of the subsequent problems. And then you have the secondary pectus, which is the result of abnormal conditions, essentially anything that is going to cause asymmetry inside your rib cage, like hypoplastic lung, diaphragmatic hernia that is associated with hypoplastic lung, pneumonectomy, especially in an early age, is going to create a vacuum, especially in the past when they were not using prosthesis inside, and as a result, the chest wall is going to start being pulled inside. Also, we see it with patients who have very significant, especially upper airway problems, and they use an extremely high pressure to overcome the obstruction, like a severe subglottic stenosis, that you need to use a lot of the intercostal muscles, and you keep pulling the chest inside, and as a result, you can develop a secondary pectus. Now, is this a problem that deserves for all of you to stay at 5 o'clock in the afternoon, you know, listen about? Actually, it is. It's not, as I said, you cannot make in general pediatric practice a living out of Pectus excavatum. However, it is the kind of topic that may occupy a very significant portion of your time, because there is not a single easy answer that you can give to the patient and to the parents. So you better, you know, have some data, you know, to support your opinions. The incidence is actually one approximately in 400 births, so it is quite common, but apparently, and you know, as we all know, it's not of the same severity, so a lot of the kids who technically do have pectus never make it to the doctor for this particular problem, and a lot of times, you know, when you examine this child, you may see that his or her chest, you know, is a little more hollow in the middle, and you say, okay, you know, this is this is a little, variation of the normal, and if the child is doing well in any other respect, usually you don't need to do anything more than that. Pectus can be seen in both genders, but it is, like a lot of other problems, more common in boys. We tend to be the weak sex, despite of the popular belief, and we're being affected by a lot of different things, including this one, or we are more crooked, whichever way you want to put it. It is hereditary in the sense that you can find, if you look, you can find members of the family who have the same problem. It can be immediate relative, like a sibling or a parent or the uncle or something like that. However, how exactly is being transmitted is not known. This list that I assume that none of you can read, I put it intentionally this way. These are some of the genes that have been associated with the Pectus, which means that essentially we don't know, okay, for all practical purposes. However, as I said, it is something that you can see. This is a picture of two siblings, who have Pectus, and as you can see, actually, although they both have Pectus, they don't have the same kind of Pectus. One is more on the flat side and the symmetric. The other one, as I'm going to point out, has some other characteristics. And another thing that is very interesting, we see it almost exclusively among Caucasians. There are also Asians. I don't think that, no, I have seen one African American in about 20 years. The literature does not provide any explanation for that. There is no known, either predisposition or preventative factor among black patients for that. We checked, actually, we did some informal studies. People assume that maybe it is cultural, and people from different races do not appreciate it the same way, or access to care for something that a lot of people consider a quote-unquote cosmetic problem. But neither of these explanations was significant enough to explain these differences. The relative, as I told you, can be found, in about 30 to 40% of the times. Now, does the Pectus present from the beginning in the same way? The answer is no. In the vast majority of the cases of the idiopathic Pectus, the baby, the newborn, and the infant looks, for all practical purposes, normal. And, as you know, with the infants, they put the baby fat, and, they have folds and all kinds of different things. They slouch, they crumble, the way they sit. So you can miss it actually very, very easily, although it is there, since it is a congenital problem, it is there since birth. It starts becoming usually more evident in the early childhood. And, as you can see in the middle picture, and then it becomes pretty prominent in the later childhood, and it becomes even more prominent during adolescence, during the puberty, and right after that. So, like a lot of other skeletal deformities, it follows pretty much the rapid growth of the body. Whenever you have the rapid growth, usually these periods are around 2 years of age and about 7 to 9 years of age, and then in puberty, this is when you start seeing the rib cage abnormalities. So why do we care about it? One is because it is something, of course, very obvious. You take off your shirt, everybody can see that your chest looks different than anybody else's. However, the most important thing from the medical standpoint is what we don't see, what is on the inside. And this is a picture of a CAT scan from a patient with Pectus. And where you see the arrow that is pointing out to the sternum, this sternum should have been up here. So the entire anterior wall of the chest is being pushed inside. And as you can see from the back of the sternum to the spine, there is only a very, very, very narrow space. So again, think of this imaginary giant who comes and grabs you and squeezes your entire chest. The idea of it does not feel, extremely comforting. So, something must be affected on the inside. So what can be affected on the inside? Essentially, there are the organs that are inside the chest, the lungs, the heart, the big vessels, the esophagus, if you wish. And then you have the rib cage itself, that if you start squeezing it, whether it is symmetric squeeze or even more asymmetric, you start deforming not only the ribs, but you start deforming also the muscles that cover this rib cage, because some of them now are going to be overstretched and some of them cannot stretch at all. And what does this do? The problem is that, starting from the outside, if you do not allow the respiratory muscles to function, you are going to have a problem either breathing in or breathing out. Now, thanks God, for the sake of the patients, this is not a problem for the regular breathing. However, when you try to exercise, and by definition, no matter how good of a lung you have, when you try to exercise, you need to take a very deep breath. And you need to use these inspiratory accessory muscles. If they cannot stretch and contract properly, you simply cannot get enough breath. So having good lungs does not do you any good. You can have the best lungs in the world, you are not going to go very far simply because you cannot inflate them to the point that is necessary. Now, how exactly it's being affected, it depends on the severity of the pectus and the exact type of the pectus. And the rib cage, although we think of it, like a little cage, fairly uniform, it is actually a very elaborate system, and each part of the rib cage works in a different way. The upper part of the rib cage works like the handle of a bucket. So as you lift up the handle of the bucket, the upper ribs start coming like this, and this is what expands the upper part of the chest. The middle ribs work in a different way. It is like the old water pumps. They go up and down. And the free ribs on the bottom of the chest, they work like a caliper. They open up like this. And this is what allows us to have this outward motion of the chest that we have during breathing, especially during deep breathing. So depending on what kind of deformity exactly and how you have and how your sternum is getting on the inside, some or all of these ribs are going to be affected, and the degree of this effect is going to determine the degree of difficulty that the patient is going to have. So although we call all of them by the same name, each one of them may have a different kind of problem. Generally speaking, what they all have is that they lose partially or completely the ability to expand the rib cage in this outward, in this bell shape. And they work actually, if you ask them to take a deep breath, they work, as I call it, with the elevator movement. They go only vertically. You see the chest just going up and down, but not outward. Now, the concern always had been, for years, that when you squeeze, the rib cage and you create this very narrow space inside the chest, especially in a very young age, you are not going to have enough space for the lungs to grow. And this is a very legitimate concern. I mean, it's a finite space. The more narrow it is, the less, space for the lung to grow. That actually is not, as a matter of fact, true. This is from a study that we did with a colleague of mine at Columbia University, and it's about 100-something teenagers, primarily with pectus, idiopathic pectus, no other diseases or abnormalities. And essentially, they all have, this is the total lung capacity, that it was for the group 95% of the normal. And the only thing that we found out actually was that they had a certain degree of air trapping, which was kind of a peculiar initially, finding, because air trapping is associated with obstructive diseases, asthma, these kind of things. And pectus in most of the textbooks is being described as a condition that is going to cause a restrictive problem. So we could not really reconcile. Then when we analyzed the data a little more, we found that like in any other condition, there are variations. So about roughly the majority of the kids actually had lung function that was within the normal, but about 1/3 of them had obstructive symptoms, and these were the ones mostly who had the air trapping, although the vast majority of them did not have any history of asthma or associated problems. And actually we did not find, we found only a point-something% that had a true restrictive defect. So in terms of lung growth, it's not, in the vast majority of the cases, it's not a major problem. Now, what it is true is that they tend to be at the lower levels of the normal, but still within the normal, and if it were a lung problem with these lungs, they should be able to do anything and everything without any problem. Then people started realizing that it's not only the lungs, it is actually the heart, and as a matter of fact, the heart makes much more sense to be affected because normally the heart, or most of the heart, is sitting just behind the sternum. So when you start pushing the sternum on the inside, it squeezes the heart, and either it's going to squeeze it against the spine, or because the sternum usually turns either to the left or to the right, it's going to displace it in one of the other side of the chest. Now, what that means from a practical standpoint is that like the lungs that during exercise need to take a deeper breath and they need to inflate more than the usual, during exercise the heart needs to pump much more blood. And in order to pump much more blood, it needs to become bigger. This is the stroke volume of the heart. And in maximal exercise, you quadruple the amount of blood that you push with every systole. So if you have the heart squeezed against the wall behind, there is simply not enough space for the heart to become bigger and pump more blood, which is the equivalent of having a car and you don't have gas. You are not going to go very far. So again, everybody realized that actually the limitation to exercise that tends to be true is for the most part due to the heart and not due to the lungs. Finally, when you start rotating and squeezing and deforming the ribs, because the ribs are connected in the front with the sternum and in the back with the spine, as you start turning them, you're going to turn the spine as well. And depending on how you turn them, you are going to develop kyphosis, scoliosis, or both. In which case then you add one additional problem, because kyphosis and scoliosis on their own can affect the cardiovascular and lung function essentially in a similar way that I described with the Pectus. So what are the symptoms? During infancy, usually no symptoms. It is more of a problem for the parents who may realize that their kid looks different and they start freaking out, oh my God, what's wrong with my baby, and so forth. The baby is happy, growing, could not care less about the problem in the majority of the cases. During school age, it may become a problem because you need just one time to undress in front of everybody and somebody makes the comment, oh, look at Billy, how he looks, and everybody starts laughing at you and you realize, oh my God, I'm a freak. Everybody thinks that I'm completely abnormal. And it becomes even more significant during adolescence when body image, even for people who are fine, at least to, an observer, every teenager feels, that they have some abnormality, and these kids do have an abnormality. I mean, they are not imagining. So clearly, it can create a very, very significant psychological problem. Now, I'm not a psychologist, and I'm not going to discuss the psychological impact, but any kind of psychological impact is bound to create a physiological also impact, in the sense that one of the common problems for the exercise intolerance that they have is that they stop exercising because they don't want to go to the gym, they don't want to undress, they don't want to go on the beach, and have their swimming suit. And then it becomes a self-fulfilling prophecy, because the less you do, the more deconditioned you become. And if you try to get up and even walk, you are going to be short of breath. So, you create a vicious cycle for something that may not have been a real, serious physiologic problem in the beginning, but it can become in the end. What is the diagnosis? The diagnosis, frankly speaking, you don't need me or anybody else to tell you. I mean, you undress the child, you see that it looks different. It's not, rocket science. The diagnostic evaluation primarily is to try to determine the severity of the problem, and primarily, like in a lot of other diseases, is this the only problem, or are there any associated conditions? In terms of the things that you can and you should do in your office, and this is, again, you don't need necessarily the specialist for that. You look at them, they tend to have a very characteristic body habitus. They tend to be very tall and very thin. Sometimes they may look cachectic, but it's not because they try to be this way. This is the way that their body is formed. Clearly, you're going to see the depression of the lower part of the sternum. The sternum may be rotated to the left or to the right, so always you try to tell them to put their feet together and stand in attention and stand as straight as they can, because this is what is going to give you the actual idea. The other typical characteristic is that as the pectus is progressing and squeezes the sternum on the inside, you have a pulling of the shoulders, so they start slouching, and then they start tilting. And that creates, actually, they all assume the typical teenage posture, like this. And it's very interesting, actually, that if you see a bunch of teenagers in the schoolyard, in the high school, they all look like if they have pectus. But, most of them, if you put them, straight, they are going to look very different. And the other thing that they have is the vast majority of them, they have a pot belly, like a beer belly kind of thing. Although they are very thin otherwise, you see this, belly extending, like in this picture. Things that you can do in the office to evaluate for associated conditions. The main condition we care about is Marfan Syndrome. Roughly up to 30%, depending on whom you are reading, of patients with Marfan have pectus. The opposite is not correct. In other words, having pectus does not mean that you have Marfan. However, you cannot tell from the outside. If a family like this one comes to your office, okay, be suspicious, that something, is strange. This is a family that every single, both mother, father, and kids had pectus. I think that was the original description, actually, from the 1800s something. The things that you can do easily in the office is to measure the arm length, and people with Marfan are going to have an arm span that exceeds their height, so it is something that can be done in the office. And then they have laxity of the joints, so you ask them to put the thumb in between the fingers, and it's going to come out. If you don't have laxity, you cannot extend your thumb beyond that point. You can ask them to put their hand around their wrist, and normally, you barely can touch. Most of the times you cannot touch with your fingers. Patients with Marfan, because of the acromegaly, they are going actually to cover their fingers, and then you can ask them to bend their fingers, and you can see easily, that there is some hyperlaxity, and in this respect, then you need to do further evaluation. In terms of the things that we do when we see them, we try to assess the severity. So we do pulmonary function testing to see, do the lungs have the normal volume for the age and size of the patient? Do they have any other associated problem like obstructive lung disease? And we measure also the respiratory muscle strength to get an idea of how affected, excuse me, of how affected the lungs. By the way, this is a typical example of choking, aspiration, and reflux. You just need one drop of water or even of your own saliva to touch your vocal cords, and you lose completely your voice. It's not the topic for today's talk, but it's a good demonstration. The other thing that we strongly recommend is progressive exercise testing, because this is really what is going to give you the functional assessment of the severity. The way you look, for good or bad, does not determine necessarily how good you are going to be when you are being asked to exercise. And this is a fairly easy, non-invasive test that can give you a lot of good details. If you decide, and for patients that we decide on either side, either us or the surgeons or the family, not to proceed with repair, then we recommend to repeat all of these tests on an annual basis, because if we see that there is a rapid and significant decrease in any of these aspects over the years, then we say, okay, the condition is progressing too fast in the wrong direction, time to do something about it. And for the Marfan syndrome, and depending on the, centers, at Columbia University, where I was when we started doing these things, we had it as a protocol that every patient with Pectus, no matter how good they are going to get cardiac evaluation and genetic and ophthalmologic evaluation for Marfan, just to make sure, that we are not going to have any surprises, especially if they end up having surgery. In terms of the severity, there have been many different ways to assess, and the most commonly used index is the Haller index, that essentially what it is, it's a very simple one. You take a CAT scan, and you measure the transverse diameter of the chest, and then you measure the distance between the sternum and the spine at the most narrow portion, and you have the ratio between the two. Normally, in a healthy, normal person, this ratio is approximately 2.5. If you have a ratio that is more than 3.5, most surgeons especially consider that as a sign of pretty severe Pectus, and of course the higher the ratio, the more severe the problem. For more than 4, most surgeons, and my colleague Dr. Bird is going to elaborate probably a little more, most surgeons feel comfortable to say, okay, this is severe enough, I can go ahead and operate. The question is it really necessary? And it depends on what we call by necessary. In order to make the diagnosis, obviously it is not. As I said, you don't even need my consult or anybody else's consult. You can do it on your own. If you want to assess the severity, and if you want to get an idea of how things look from the inside, especially before somebody starts either opening or pushing things inside the chest, it is probably a good idea to know exactly the exact anatomy and location of the different organs. You don't want your surgeon to find out in the middle of the operation, oops, the heart is not where we thought it was. They better know about these things. So more and more now it has become in a lot of centers a fairly routine assessment of the patients in order to have a clear idea of how they look from the inside. And at this point, I'm going to stop, and I'm going to introduce my colleague, Dr. Bird. I was planning initially to describe the different surgical repairs. However, I think that it is much better to hear it from somebody who actually does this stuff. I only recommend. And
okay, over the next 1 to 2 hours, I'm going to talk to you about this, the surgical repair of Pectus. And let me just warn you that, first of all, let me introduce myself. I'm Randy Byrne. I'm a pediatric surgeon at Children's. I joined the faculty about 2 years ago. I have another hat that I wear as I'm chief of trauma and burn care, so you may see me through for that portal too. But my practice is mainly in general pediatric surgery. So here's what I do for the patients. When they come in to see me with Pectus excavatum, I look at whether it's mild, moderate, or severe using the Haller index. If they're mild or moderate and they're not a surgical candidate, recommend an exercise program and sometimes bracing. And I'll talk to you about the subtleties of that for Excavatum patients. If they're moderate or severe, the tests that we get is PFTs, cardiac echo, MRI or CT to get a Haller index. And one of the main reasons, besides finding the physiologic reserve of the patients, is that we have a main concern as a surgeon for these patients when they come to us and want the operation, is that is convincing the insurance company to pay for it. And so part of the motivation for us getting the imaging of their chest to get a Haller index is to provide a number to the insurance company to support the patient's desire to have the surgery. And then we already talked about the cardiopulmonary symptoms. So there's basically two operations out there. And here are the two people that the operations are named after, the Ravage procedure and a Nuss procedure. And given a choice, I think I'd rather pick Dr. Nuss. He's more of a colorful, smiley guy. Dr. Ravage is just a much more severe, dark kind of character. So it turns out that most pediatric surgeons have gone with Dr. Nuss, I think probably because of his warm smile and colorful face. So let me just ask you not to take any notes at this point because I don't want you to do this operation at home or in your office. So I'm going to tell you how we do the operation, and please just keep it for your own edification. Don't use this for any other purpose. So the Nuss procedure is basically the following. The chest is concave in, and the goal is to get the chest concave out. And so what we do is you take a bar and insert it under the breastbone and cause the chest to concave out. And so you can see sort of a simple diagram. We put it in, it's curved the wrong way, and then we flip it up, and then it corrects the chest deformity right away. So here's how we do it. And this, again, please don't take any notes. The patient's asleep in the operating room. We take an orange flexible bar. It's a bar that I can bend with my hands. And I put it across the patient's chest, and I fix it to the configuration of the patient's chest, the way that I want it to be. Then I go over to a side table, and I take a metal bar that's I get to choose based on the length of the orange bar. I choose a metal bar. And the flexible metal flexible orange bar, I use to fashion the steel bar into the exact configuration that I want, using a bender, using a bar bender, and that's what this picture is showing here. So then this is the part that makes you swallow when you do it, is what we do is we take a passer. It's a long metal bar about this long, and we pass it from incision on one side of the chest to the other side of the chest. When we do this, we turn the EKG monitor up loudly so that we can hear the patient's pulse, because we pass across the heart. If you notice any cardiac arrhythmias or any change in the pulse rate, that's when you need to be cautious and kind of back off. When you first do this, it's a good idea to have a cardiac monitor for yourself as you're passing this bar across the chest. Dr. Nuss's procedure has been spread across the country, and it has in fact been reported that this bar has passed through the atrium and patients have required emergency surgery to fix cardiac problems. So you can see there's a thoracoscope there, and so what we do is inflate the chest, so when we pass the bar from one side of the chest to the other, we can see actually where it goes. So once the bar is in place, what you do is you take your hands and push on the chest. This is something Dr. Nuss teaches everybody. I'm not sure it makes any difference, but Dr. Nuss says if you push on the chest once you get the bar in, then it actually causes the chest to kind of fit to the configuration that you want. So then you take the bar, and there's a hole on the end of the bar, and you tie a piece of string to it, a surgical string that is, and you pull it through, and now there's a piece of string that goes from one hole to the other. So now we still haven't put in the bar that we pre-bent based on our orange template. So here is the bar, lubing it up to make it across the chest safely. And so you take the string and you pull one side, and you take your pre-bent bar and you bring it across the chest from one hole to another. And again, everybody needs a cardiac monitor when this part of the operation occurs. So here it is. Here's the bar. It's upside down. You can see it's going from one side of the chest to the other. And so now you need to flip it. And then so actually we have a device to help flip it. It's called a bar flipper. And so we flip the bar upside down, and so now the chest is in the configuration that it wants to be. You put a little bandages on there, and everything's great. So here's when I see patients for this operation, I tell them, they say they want the operation, and we do preoperative screening, they're appropriate candidate. I tell them one thing as the very first thing: this operation hurts. Because the typical patient is a teenage male who's had this for many years, and we, in one fell swoop, correct their chest deformity. And so even though this operation is called minimally invasive, yes, it's small incisions compared to the traditional ravage operation, but it's maximally invasive in the sense that this operation hurts. And these patients need to be in the hospital between 5 to 7 days, and their main reason for being in the hospital is for pain management. We give them a PCA with morphine, we give them Toradol, they go home on oral narcotics. The older you are, the more the operation hurts. The younger you are, the less it hurts because your chest wall is more pliable the younger you are. So the typical patient is in the hospital for 5 to 7 days, and then for the first month, they can't do any physical activity, just need to hang around. I tell them they can't go to school because they're probably not going to feel like going to school, especially since for about 2 to 3 weeks they may need oral narcotics, and it's probably not a good idea to go to school when you're taking out oral narcotics. Once that first month is over, no contact sports for 3 months. After 3 months, you can do whatever you want to do. I've had kids play lacrosse, football. I had one family that went to Club Med, and they had one of those fancy Club Meds where they have the trapeze stuff like the circus. You guys may have heard of that, and they did that, and they sent some pictures, and apparently the chest actually did okay. So, and then I see them for follow-up visits. I see them 3 months, 6 months, 1 year, then 2 years, and at 2 years is I have a conversation with them. Do you want to keep your bar in longer? If they say, I don't care, I don't notice it, it doesn't bother me, then I leave the bar in for even longer. If you take the bar out too soon, the chest collapses and you go back to where you were before and sometimes have to repeat the operation. So if the patient at 2 years is happy to have the bar in place, I let them go a little bit longer. The operation for bar removal is an outpatient procedure, same-day surgery. They come in, their operation itself probably takes about 45 minutes to an hour. And to remove the bar, you just reopen the incisions, and then we use a special instrument to remove the bar, and you guessed it, it's called a wrench. We actually take a vice wrench that we have sterilized and grab the bar and pull it. And that's literally how this is done. And then the bar comes out, and everybody's excited and happy because we're done with the whole affair. So the common questions that I am asked is what's the bar made of? The bar is made out of stainless steel, and the patient has a metal allergy, and we always ask the patient, do you have problems wearing jewelry, do you have a rash or something like that? If they have that, we send them for formal skin testing. If they have a metal allergy, we need to use a titanium bar. Now the problem with the titanium bar is that if you scratch it, tissue will incorporate into the bar. So we have to have the bar pre-fit, so we have to take a CAT scan, send it to the company. They look at it, they guess what the bar will be, and then they send us back the titanium bar. We absolutely can't scratch it because when you go to pull it out, it ain't coming. So you have to have the bar all set. The bar costs about $1,000. CPR can be provided. You just have to put a bit more force, and you can successfully do it. When you defibrillate, you need the pads on anterior and posterior, not in the typical positions that you normally have. You can do an MRI, but if you do that, you probably will have some scatter on those imaging, not surprisingly. And a very common question is, can you go through the metal detector at the airport? And the answer is yes. But I give the families a note that says, Dear guy at the airport security area, this patient has a bar in their chest. Please don't give them a hard time. But I don't think anybody's ever had to use it. But I give them the letter anyway. They kind of like it. I also give them a medical alert bracelet if they want it. And a medical alert bracelet just says what this slide says, except it doesn't have the $1,000 thing on there. But it says basically what this slide says. So the ravage procedure is a traditional operation that was done until Dr. Nuss promulgated this to the pediatric surgical community in about 1997. He'd been doing it for several years, but brought it sort of mainstream in 1997. The ravage procedure for many, many years was the standard operation. And the simple concept of this operation is that what causes the chest wall to be forward is abnormal cartilage growth. Cartilage is in an abnormal configuration. So remove the abnormal cartilage, leaving the perichondrium in place so that the cartilage can regrow into that space and bring the chest wall forward, bracing it with a metal brace or just leaving it. This operation, one of the reasons that pediatric surgeons abandon this operation is for a simple reason, I think. I think. It's not because of cosmesis, it's not because of outcome, it's because this takes 4 hours and a Nuss procedure takes 45 minutes. This operation leaves a scar that's probably about this long. It can be a little bit less if you're pretty good at it. But if you have a patient with a complicated pectus, the incision is this big. It can be an up and down incision. It can be, most people do sort of a transfer submammary incision. Just a few comments about the difference between these two operations. I don't want to show that just yet, but the difference between these two operations, if you look at the complication profile, the profile is slightly different between these two operations because they have a different concept. So in the Nuss procedure, one of the complications, for example, is the bar rotating. So the bar is like this, and they can literally flip upside down, which I had happen one time, and it's not really a good thing to have happen. You have to flip it back. So the bar can flip. Whereas in the Ravage procedure, because there's not this big metal bar, clearly there can be no such complication as the bar flipping. Another issue is about bleeding. Is in the Nuss procedure, since you're not doing any kind of resectional treatment, you're not removing anything, you're just putting this bar in and moving the chest forward, bleeding is really sort of an unusual complication, whereas bleeding in the Ravage procedure is more common. So it's really hard to compare the two profiles. When I select the operation for the patients, I tailor the operation based on the patient. The vast majority of patients who have symmetrical pectus are perfectly good Nuss candidates. Patients who have severe pectus, who are teenagers, I believe, benefit from the Ravage procedure. I think they have less pain, their outcome is better, and I think they're happier with the ultimate cosmetic result. So I think it's good to have both operations in your armamentarium and select it based on the patients that you have. Now, people are coming up with some other really super cool ways to do it. So if the problem is that the reason this operation hurts is because you're bringing the chest forward in one fell swoop, why not do it slowly? So Mike Harrison, who is the guy who invented fetal surgery, is tinkering around in his lab at UCSF and came up with this idea. Why not put a magnet underneath the sternum and then have another counter metal object that you can put into a plastic plate on top of the chest, and that will allow that the magnet will slowly be attracted to that plastic plate. And so there's a couple considerations. First of all, is it safe to have a high-powered magnet next to the heart? And the answer is yes. They had to do some testing to convince the FDA that you could do that. And they're now in a trial looking at using this. It's kind of an interesting thing because the kids have a magnet in their chest so they can hang metal objects off their chest. So it's kind of an interesting little quirk that occurs. So here's another. Why not just use the vacuum device? Well, this works. This actually works too. The problem is this requires kind of a highly motivated patient, and you can get redness and stuff like that on your chest. So this is an operation of sort of interest. So what about patients who don't require surgery? What kind of things can you do for them? So if they don't have a Haller index, this is high enough, and they say, I don't like the way my chest looks. So here's some things that I recommend. They can send them physical therapy to do strength training and stretching to help their kyphotic posture. Get them to stand up. They stand up, the appearance of their pectus looks much better. The second thing is if they are thin and they don't have much pectoralis muscle development, have them start doing push-ups. If they develop muscles on their chest and develop the chest wall muscles, the appearance of the pectus is much better. And then finally, I've tried this in a few patients. I'm not sure how well it really works, but these patients typically have costal flaring. The bottom part of the rib cage sticks out. And I've had some kids where I braced the lower part of their chest in an attempt to help the appearance. I'm not sure really what the real success of that strategy is. Let me talk about another entity that is usually in the same chapter, which is pectus carinatum, where the breastbone sticks out. Because the breastbone is sticking out, you don't have the cardiopulmonary issues related to this. It's sort of going the other way. And so my strategy, I get a chest x-ray. I'm not quite sure why. I just want to make sure that there's nothing fundamental about the patient that I'm missing by not getting a chest x-ray. And then almost all the patients are good candidates for bracing and physical therapy. If they have good results from bracing, then nothing else needs to be done. If they don't, then they can be considered for surgery. And I think that surgery for this entity is rarely required. And so the physical therapy again is if you develop the muscles and you help posture, develop muscles on the chest and help posture. You don't get rid of the pectus carinatum, but you kind of make it look better. And so the brace is, I'll show you a picture of the brace here. You wear it for 23 hours, except when you're, I don't know, when you can't wear your brace, when you're taking a shower. It's effective in greater than 75% of patients. This is from largely my personal series. I've only had a few patients that have not had a dramatic response. And the treatment is really, you keep the brace on until the patient likes the way their chest looks. There's really no formula to doing this. And if you wind up not bracing fails, you have a problem with doing that, then you can do an operation. So here's what the brace looks like. It's basically a pad that sticks on, that's on the front part of the chest. It doesn't stick on. There's a pad that lays on the front part of the chest, on the prominent part of the sternum, and then it has a similar pad on the back. Then it has two buckles on the side, like ski boot buckles. You know, when you go skiing, you want to tighten your ski boots up nice and tight so you don't hurt yourself. So this is it. So what the kids do is they tighten it down until there's a little bit of pressure. In the first week that they wear the brace, the kids describe the sensation of somebody standing on their chest. And more than one kid has had mom kind of staying with them at night because of that sort of suffocating feeling that they had when they put on the brace. But then they get used to it. And the absolute amazing thing about the brace is I've had kids that in 2 weeks, their chest wall appearance is nearly completely, almost completely fixed. Now that's not everybody. Now the bracing works better the younger you are because your chest wall and cartilage is more pliable. The other sort of quirky thing that when I started doing this that nobody explained to me, but kind of makes sense, is that when you start putting on this brace, is that because the cartilage is moved so quickly, the sternum actually kind of floats back and forth. It's sort of floating. And so when you push on their chest, it sort of moves in and out. So I usually see these patients early on to reassure them that all these things that I observed are not problems. So thank you for your attention, and hopefully it didn't take 1 to 2 hours.
And since I cannot have a surgeon to have the last word, essentially the whole issue becomes now, after you heard everything we told you, what is to be done, or anything can or should be done. Clearly, Dr. Bird said that a lot of things that can be done. Whether you do them or not is a matter, this is where the controversy starts. The point of my talk, and I hope that it is the take-home message, is that it's not a cosmetic problem. It is something visible, and clearly there is a cosmetic component in it, but it is a physiologic or pathophysiologic condition that may affect a number of functions, especially the cardiovascular and pulmonary function. Whether you decide to repair it depends both on the physician and on the patient. To some extent, you know, because there is this thing, oh, it's cosmetic, it is an issue of vanity, you know, you want to look like a star or like an athlete or whatever. This is not what we're talking about. It is a reconstructive surgery. The analogy that I often use, both for patients and insurance companies and everybody else, is it is in many ways the same way that I would tell for a woman who had a mastectomy. Technically speaking, she does not need the breast to survive, to live her life. But I cannot tell her that it's just a matter of vanity that you want to repair it. She just wants to be the way she used to be before. And for these kids, we think, or at least I think, that it is a reconstruction that they want to be like they were supposed to be in the first place. Now, whether you are going to do it or not, it's a totally different story. One thing that to keep in mind is that the repair is not going to improve, especially the pulmonary function, and this is something that the patient and the parents have to understand, that nothing is going to change most likely in terms of the lung function, and sometimes actually, especially if they had a really bad pectus, you may see even decrease in the lung function because the surgeons have become very good in correcting the rib cage, but still they have no idea how the muscles are going to work in the new configuration. They close, the area, everything looks nice, but that does not mean that these muscles that for the past 15 years were used to work in a particular configuration are going to work as well in the new configuration. So this is something that has to be very clear. The cardiovascular function usually improves somewhat because the heart has more space to work, and to some extent probably because the patients feel much better and now they go out and they start exercising and they start having physical activity, so they do improve. Which procedure is the better one is actually a very interesting point, and especially, you need to read the surgical literature. Essentially, the best surgery is the one that the particular surgeon and the particular institution have become really experienced with. I mean, if you go to Norfolk, Virginia, where Dr. Nass is, definitely they have excellent results. I mean, they have done the most than anybody else in the world. They have become really, really good at that. And a lot of surgeons right now, for the reasons that Dr. Bird said, they use it and they have become and they are becoming on a daily basis, more and more proficient. This is a study and this is indicative. I'm not pushing it, as a conclusive, but this is from Mayo Clinic, and they are probably the only hospital that they use a third procedure that is sort of closer to the ravage, and they essentially, looking at their patients, they essentially concluded that the NAS is the worst in terms of results, operative time, length of stay, and expense. This is not something that is being shared by other institutions. So surgery is something that there is a significant learning curve. So if an institution and the particular physician are proficient and they have good results, I would trust them to do the operation. So as far as I'm concerned, at least from reading and following patients, there is not a single best procedure that is best for everything. People who are against the operation are against in the sense that if you are not going to improve significantly the lung and cardiovascular function, why do something invasive? Which, like any other invasive procedure, carries a certain risk. The pro-argument is what I told you before, that it's a reconstructive surgery, and I cannot tell the patient, or at least I feel that I cannot tell them, you should not do it. I'm not going to twist their arm that they should do it, but I'm not going to tell them that this is a grave mistake, if you decide to go ahead, if up to this point you had effects, whether it is the physiologic or the psychological, that prevent you. And this is from a recent study also. This is actually from Norfolk, when they asked the parents and the patients before and after the surgery, 2 years after the surgery, how they felt, and both the patients and the parents felt that their quality of life overall had improved significantly after they had the operation. So in this respect, I don't think that anybody can tell them, don't do it. Whether you are going to push for doing it, I would not recommend that either. I think that every patient who comes to you to ask for advice deserves a good evaluation, both from the surgeon and from the medical people, at least to have a clear idea of what we're talking about. So it's not just the way you look, but how it's affecting your body. And then you follow them and you make finally the decision on whether you should proceed with the surgery or not. And I leave you with that. Thank you very much again for your attention, and see you next year.
I have to ask, are there any questions? Oh, wait. There was somebody else, Giorgio. What's the youngest patient?
Oh, yeah, that's a very significant point. Initially, in the 60s, 70s, people thought that you should operate as early as possible in order to allow the lungs to grow. And that was a major disaster because although the surgeons might have done an excellent repair, the cartilages and the bones were not formed enough, and a lot of the patients actually ended up with very severe complications, asphyxiating thoracic dystrophy essentially. So most people now, very, very few, if any, operate in less than 8 years of age, and many people, including myself, prefer actually to wait for the puberty because you know that the body is going to change. So puberty is still, and my colleague here, can tell you much more because he does it, but puberty is still, the bones are not rigid enough that make the operation extremely difficult, and you know how the patient is going to look for the rest of his or her life. So I would vote around that time.
Yeah, the average age for the operation has increased over time. And now we use the 8 years old that was mentioned, and part of the reason we use that is that's what Don Nuss declared, and all the people he trained was the minimum age you should do the operation. So everybody's just adopted that, and that's become the standard party line. It's sort of interesting how that number came about. The optimal age is when all the stars are in a line. I think the operation is helped a lot by the child having the motivation to go through the procedure. And so if you have a kid who's 8 years old and parents bring him in and they're not even sure there's a problem with their chest, that's a disaster waiting to occur. If you have a teenager who's coming in dragging his parents, that's a good situation waiting to occur. So let me answer from my perspective. So I see a highly biased population because they're coming through the door on my office says surgeon. So they know that somebody might be talking to them about an operation. So if you look at the patients that I see, sometimes they're just coming for information. They haven't had the opportunity to get information, and I just provide them information. And I present this as a very neutral thing. So the simple answer to the question is probably about 50% to 75% of the patients wind up getting an operation. And that's just sort of a number off the top of my head. A significant number of patients that I see don't want to have the operation, and no matter how severe their pectus is, if that's their choice of what they want to do with the information that's presented to them, I allow them to make that choice. I think this is an operation with risks, and if the family and the child doesn't choose it, I think that it shouldn't be done. So probably about 50%.
Well, actually, the real answer to your question is how many people do you refer either to the pulmonologist or to the surgeon? Because I agree with Dr. Bed, even for my practice, by the time they come to see me, they have almost decided that they want the repair. There is no, because in every center, everything is biased. I mean, we all know the patients who came to us, and they came to us because they had decided that probably they want the operation, and unless either myself or Dr. Bed says no way that I'm going to do it, they're going to have it. So it's a very biased sample. It's a very good question, but the general pediatrician is the first person who's going either to encourage, discourage, or at least be neutral, to the patient's request.
I think it's sort of an autopsy question. How many patients have uncorrected pectus at autopsy? However, that's hard to look at too, because yeah, absolutely. And I would do this if I were in the primary care setting. I would say your child has pectus. If you're not bothered by this, or your child's not bothered by it, I am absolutely not bothered by this. If you see that it's obviously their breastbone is hitting their spine, then, I mean, the ones that common sense would say something would be done. I have had patients, I just absolutely don't believe this, but they said, the pediatrician never said anything to me. Well, I don't believe that's ever true. But I think if they have it, just tell them they have it. Tell them that tell them that there's options, but the options are things that's completely up to them, and they don't need to choose to do them. I think that's the approach that I would take.
Like any other disorder, but most of them that we see, as I said, are mild, looking, appearing, and just common sense says you do all these tests, most likely they wouldn't be normal.
And you shouldn't. You shouldn't do those tests if it's mild. If the common sense says it's mild and they're not interested in doing anything, don't do anything.